Division of Geriatric Medicine in collaboration with the Division of Hospital Medicine to talk about an update in our hospital at home program. If you all remember, you all will have to correct me. It kicked off about a year and 3 months ago now.
Last January.
Last January, right? So there was an initial update last June, and this is an update from that. So let me introduce our speakers. Today, we have Dr. Gordon Pace. He's a hospitalist and co-medical director of the VCU Health Hospital at Home. Dr. Pace graduated from VCU Medical School in 2015, completed his residency at Yale New Haven Hospital Internal Medicine Primary Care Residency Program, returned to VCU after graduation where he practiced as a hospitalist, has been practicing for the last 6 years. For the last 2 years now, he's been co-medical director of the VCU Hospital at Home program with Dr. Breton. Dr. Julia Siegel Breton is a board-certified geriatrician. She attended the University of Virginia for undergraduate and graduated from the I2CRP program here at VCU in 2012. She then moved to Boston and attended Tufts Family Medicine residency program, followed by Harvard's fellowship in geriatric medicine. For several years after her fellowship, she worked in Boston as a geriatrician in an innovative program where she provided home visits for low-income seniors. Her role included figuring out how to manage serious medical conditions within a patient's home instead of the emergency room or hospital. She later became core faculty for the Harvard Geriatric Medicine Fellowship Program. I think she also ran a COVID unit for a while. Since returning to Virginia, she's joined the faculty here in the VCU Division of Geriatric Medicine and leads our Continuum Integration Center as the medical director. Includes programs such as VCU Patients at Home, including remote patient monitoring and hospital at home. So warm welcome to both of our speakers. Who is going first? All right. Come on up. Thanks.
All right. Thank you so much for having us back. As Dr. Bergman said, we were here a year ago. Last year at our grand rounds, we were really introducing the concept of hospital at home and also describing how the first 6 months had gone. We had an interview with one of our nurses, and we even had an interview with one of our active patients on our service, which is very cool. Today's focus is going to be a little bit different. We certainly are going to give you some updates, but we're also going to focus on equity and safety in home-based inpatient care. I'll really quickly draw your attention to, we're going to use the term hospital at home. So originally there was a slight overinterpretation of some copywriting law, and we thought that we couldn't use hospital at home, so we called our program Home Hospital. But we are now able to align our name with the national and international title, which is hospital at home. All right, so we'll give a quick refresher. We'll give some statistics of our hospital at home program at 18 months, describe some medical complexity of patients that we've cared for so far, some of the benefits we've seen, and our safety statistics. We'll talk about some of the social complexity that we've managed in our ongoing strive for equity. We'll talk about patient satisfaction, and we'll wrap up. So some very quick foundation. So hospital at home is acute inpatient care provided in the comfort of a patient's home rather than in the brick and mortar. It is another unit of our hospital. It just happens to be in the patient's home. This practice has been international for decades. It's more newly adapted in the US. And it may be one of the most evidence-based health service delivery innovations in the US currently. I'm going to quickly run you through a day in the life to describe our hospital structure, hospital at home structure. So first step is our enrollment RN care coordinator and our hospital at home hospitalist, let's see an abbreviation, HAH. Use well-developed medical and social screening criteria to determine if a patient is eligible and then offer the patient to the program to those who are eligible. Patients can be transferred to hospital at home directly from the ED if they're meeting inpatient criteria, or from an inpatient unit. Our hospital at home hospitalist assesses the patient in person before transferring to hospital at home. Our hospital at home team then coordinates all the services needed at home. That includes DME, like a hospital bed, wheelchair, walker, bedside commode, you name it, oxygen, including concentrators, tanks, nebulizer machine, medications. All of our medications come from our inpatient pharmacy, which have been absolutely outstanding to work with. All the supplies, including any infusion supplies. We offer our patients food if they would so desire it. We set up and provide the transportation. We also provide rehab services, the remote patient monitoring technology for virtual visits, for vital sign monitoring. All the patients in this program receive a minimum of 2 scheduled in-person visits, RN or medic, every day, as well as the option for an as-needed urgent visit. They also have a 24/7 virtual RN. This is a VCU nurse who's available 24/7, as well as care coordination support. And we have a hospital at home dedicated social worker. There are daily virtual provider visits with their hospital at home hospitalist. And things that we can do, we do labs in the home. We're checking their vital signs at the same frequency that they would be checked if they were in the brick and mortar. We can do bladder scans, provide them oxygen, IV treatments like IV antibiotics, IV Lasix, rehab services, PT, OT, speech therapy. They can get virtual visits with consulting specialists. They can be brought in directly for imaging or procedures and then go right back home. So if they need an echocardiogram, they come in, they go directly to get that echocardiogram, and they go right back home. And this is all fully integrated in Epic. It appears exactly the same as any inpatient at VCU Medical Center. And all of this with multiple redundancies in place to ensure safety and quality of care. Should a patient need to be transferred back to our brick and mortar, it is a direct transfer to an inpatient unit. So who's a good candidate? Most people. Adults living in the Richmond metro area. We can also use doorways with our hospitality house if they are outside of the Richmond metro area. I'll discuss a little bit more about that later. We are looking for patients who are not expected to decompensate, but still require inpatient care. So they still need the inpatient active level of monitoring, diagnostics, and treatment. Who can we not take care of, but who's not a good candidate? Patients who are on dialysis, patients who are still needing IV narcotics, patients with an anticipated emergent need for blood products. And I highlight emergent because we have actually coordinated urgent need for blood products. But if it's needed, in 5 minutes, we can't do that, but within the same day, certainly. Again, highlighting emergent imaging, emergent procedures, and new oxygen requirement of greater than 4 liters. All right, I'll let Gordon take it from here.
I get the boring part of tables and statistics. I will say all the stuff we provide at home that Julia just mentioned, it's amazing how quickly it happens. So DME, oxygen, nebulizer machines are all brought in initial enrollment within just a couple of hours of them being there. I mean, it's amazing how quickly this stuff gets to the patient's bedside and arrives at home with them. It's a very, very efficient process at this point. So our first year summary here, we are now at 300 patients as of yesterday. It says 297, but those are discharges, and we got 4 or 5 enrolled in the program today. So we've reached the 300 threshold of patients who've enrolled in the program. There's a little, just to note, there's another number here in patient discharges of 267. That means 30 patients have enrolled in the program and had to come back for some reason to the hospital and are discharged from an inpatient unit. We'll get into those escalation rates a little bit later. But over 300 folks have been enrolled in the program in the first 18 months. And that's with a lot of issues that I'll bring up later is regarding our census. The original, where folks come from in the hospital, primarily internal medicine services. We've got folks outside of house staff services and hospital medicine, but the vast majority are from the internal medicine services. Medicare has been our primary insurer, and that has to do with a lot. The first 4 months, we only took Medicare patients. And so they're a much higher percentage than other insurers. At this point, we will take pretty much any insurer except for one, and that insurer will remain nameless. We don't like them very much right now. And where do they go when they leave? When they leave the hospital? Well, most of them, nearly 95% or so, go straight back to the home. We've been able to arrange discharges to hospice, discharges to inpatient rehab, and discharges to skilled nursing facilities from the comfort of a patient's home. The next few slides are about enrollment and growth over the first year. I just want to take you through a timeline of trajectory. When we first came in, we thought maybe we'd ramp up pretty significantly and have a couple dozen patients in the program. But there's a lot of issues with growing a program like this that's as complicated and inefficient to start. This is an average daily census over time. So the bar on the left is the total number of patients enrolled in the program. As you can see, the peak number of patients at midnight has been 7 a few times, with a general upward trajectory. We'll go through this step by step. As we started the program last January, there was a low census to be expected. We've got to start, build efficiency, figure out how to get meds home, figure out how to get nebulizers sent home, make sure patients are clinically stable, and recruit. This time, we also could only take 20% of the population that were Medicare. So we started the program as only Medicare patients. And with the number of people in the hospital, that's clearly going to limit some of the enrollment numbers. After those first 4 or 5 months, our efficiency was built, and then we began to take on more insurers. So more insurers started arriving in June, and we got up to about 40 to 50% of insurers on board at that time who were contracted to pay for home hospital like they would any other patient in the hospital. There was a steady rise there for a little bit, and then over the summer, as we were still finding our feet, there was a plateau for a couple of months. So insurers were on board, more insurers anyway. Patients were becoming more interested in the program, and providers were referring, but the enrollment wasn't ticking up quite as much as we had wanted to. So we tried to become creative with ways to get more folks into the program. So we introduced a BPA that has annoyed probably several of you over time, but within the first 24 hours of admission, if a person is seen in Epic to be a candidate for home hospital, a best practices advisory pops up and a consult is requested. Now, people can click out of it or click into it, but that generated another little bump in our enrollment over the next month or two. And then what really started to increase the trend in these kind of gold, blue, and green figures is we became a payer agnostic approach, which we said, if we even don't have an insurance company that's contracted to cover home hospital, we're going to roll you anyway and figure it out on the back end. So we'll now take pretty much anybody in the hospital that qualifies for the program, regardless of who their insurance company is. And after that payer agnostic strategy started, there was this rise that was going up, and we were feeling pretty good. And then we suddenly had, like everybody else in the world, had in-home staffing shortages that limited our enrollment. So right when we were starting to feel good about the growth and trajectory, we had a decrease in staff, and we were only able to keep the census at 3 or 4 for a number of months. During that time, it's important to note that we kept really at a near maximum capacity for those programs. So we're keeping people at 3 or 4 a lot of those days. We now have restaffed up our in-home services, and census is rising back up. But a bit of an ebb and flow, but an overall trajectory that's been really pleasing to see over the first 18 months. And in regards to how it compares with national institutions, there are a few programs that have 10 to 20 patients in their home hospital programs, but folks that are academic institutions of similar size, it makes VCU one of the largest programs in the country. This is the average inpatient discharges per month from home hospital program. As you can see, we were having a nice trajectory of discharges from home hospital that was rising until we had that staffing shortage in the middle of the winter last year. And now it's picking back up again, and May looks to be a very good month as well. One of the things we've been trying to figure out is we've got this best practice advisory that tells people to send a bunch of consults in. Is it actually being effective, and are people actually using it? And when we get consults, are people enrolling in the program once we get the consult in? So Dr. Steve Biederman has been working really hard on a paper and put together some fantastic graphs, and this is one of them. So this is after the BPA was introduced in September. Since that time, we've had 724 consults to home hospital. So we've got an order in Epic nearly 750 times that a person can potentially come in to enrollment. And again, this is months 7 through 12, so it ended in January. So from about September to January. 212 people, 30% were just ineligible to start. Maybe an accidental consult was placed, they were on dialysis. Maybe their oxygen requirements were too high at the time. Maybe they had too much antibiotic need at the time and they couldn't enroll. 20% just said, I'm not interested for whatever reason. Maybe their plumbing's getting worked on at their house. Maybe they're uncomfortable with people coming in the home. Maybe they've got angry dogs that will bite our staff. A variety of reasons why people don't enroll in the program. And then there was a fair amount of folks that would passively decline, that would say, I'm interested, but I want to think about it for a day. I want to think about it for another day. And then they're discharged. And we lose them from just the game of discussing and talking and waiting, and they can't ever make a decision about what they want. So of that 724 consults, a total of 22% enrolled. And that's a number we're trying to get up. We're trying to make the BPA more accurate, get the number of potential enrollments that are facilitated by that BPA to increase. Reasons why people may be ineligible from the last slide. Again, some great work from Dr. Biederman. Acuity and complexity. We have in-home staff from 7 a.m. to 7 p.m. If they need 3 times a day antibiotics or 4 times a day, they can't enroll in the program at this point. As our staffing increases, hopefully to 24 hours, we can take more and more people. We now take this middle chart was back when we weren't taking certain insurers. So that 51 is going to be gone soon, and hopefully that will increase our enrollment numbers as well. And another reason people are ineligible is that a significant portion are deemed by utilization review to be observation patients. And CMS does not allow us to take patients into home hospital if they're observation. And that's a big hindrance on the program and a big hindrance on getting folks out of the CDU and out of the emergency room. Hopefully at some point we can change that as well. The reason people declined home hospital, let's say they're a great candidate, they look wonderful, their antibiotics are appropriate, or they need just once daily diuresis. A lot of folks just want to stay here. It's a break from being home, and they just want to stay. A big portion is home conditions. You know, maybe their home is in a great position. Maybe they live in a neighborhood that's tough. Maybe nursing visits at night aren't particularly safe in certain instances. So there's home conditions that we have to take into account when enrolling certain patients, and a variety of other. There is a small portion, the blue box, the number 13 on the right side, is that some people just don't want to do it. They want to, if they say, if I'm going to go home, I want to go out to eat with my friends and come back home. I don't want to feel like I'm still in the hospital, because when they're in a home hospital, they have to stay in their home and they have to be in video contact all the time. And certain people just don't want to adhere to the program. One big thing that we're trying to do is offload lower acuity folks, particularly new admissions. We've got a lot of ED holds. And one of our big focuses is getting folks out of the ED or on day 1 of their hospital stay, so the rest of their hospitalization can be at home. And as you can see, most of the departments where we're getting home hospital consults is the emergency department. So the most of the people that we're getting consults from are exactly the folks that we want. Folks in the emergency room who are clinically stable but still need inpatient care. The rest of the units, as you can see, are from mainly medicine units. I just found this interesting going through the statistics, that as our insurers have changed, the average age of enrollment of home hospital patients has declined steadily. I think it'll probably plateau around that mid-50s range, but as we're only taking Medicare patients at the start, the average age was 67 to 73. And as more insurers have come on board, and as probably a younger population has been interested in the average age of who we're taking has dropped steadily over time. It'll be an interesting trajectory too.
I was going to add a fun fact. I think our age range has been from 18 to 102.
Yes, 103.
103.
We're going to add another year. She's probably 103 now. Another interesting statistic that we're keeping a look at is readmissions. You know, one of the goals of the program is provide comprehensive care in the home. With physical therapy and occupational therapy and speech therapy, they can go into the home, evaluate the home environment while also taking care of the patient's physical needs, with the goal that maybe we can help structure their home environment in a way that's more conducive to holistic health. And as you can see, these are readmission rates. The top line is a 7-day readmission rate. The middle line is the 30-day readmission rate. And again, as we were taking some of these older, sicker patients as we started, the readmissions were higher. But over time, that readmission rate over the last several months has dropped. Again, more efficient in-home services, probably better selection of patients. And there's some qualifying factors that may also be making that drop. But as a comparison, these are also those who have been discharged from their home environments. The number's a little lower here because this is from April. But these are folks that have been discharged from their home environment, not folks who escalated back to VCU and then were transferred from VCU. And one more thing to note, the VCU admission rate from our website is 14.9% over 30 days. So a significant difference from VCU's overall rate. And again, it's a subset of patients that may already have a baseline lower readmission rate. So there's some ways to figure that out, but we're very happy with the trend of it over time. Most common diagnoses, we thought CHF, COPD, pneumonia, cellulitis, and looky there, that's exactly what the most common diagnoses are, but it's not the only folks we take care of. So heart failure is by far, when you add them all up, heart failure and sepsis and other infections are by far the most common folks that we admit, but there's a whole host of other folks that we've admitted as well. Still me. She's coming back up. The next few minutes, as we transition away from statistics, one of the things that Julie and I wanted to really talk about is how this affects patients individually, because I think that's what the real benefit is. We can talk about facts and figures and statistics all day, but how does it benefit patients and how do patients feel about it? One of the things we didn't expect going into it was how complex our patients would be. We expected CHF, give them diuretics, and then they would go home in 3 days. COPD, prednisone, home in a few days. But because of our patient selection process and a fair amount of folks saying they didn't want to enroll, we've had to expand to a little bit more sicker patient population than we first anticipated. The first example is a classic case. Somebody comes in with CHF, they're volume overloaded, haven't had an echo in a while, and they need diuresis and a right heart cath. So we're able to bring them home and we diurese them for 4 or 5 days, bring them back for their right heart cath, and then they can discharge and we get a really good euvolemic state, as well as seeing what their house and their refrigerator looks like to see if they can have a little better dietary adherence.
Yeah, I can talk about the next one. We had an older gentleman who was living alone, no family or anyone nearby who could assist him. He had pulmonary sarcoidosis, many hospitalizations. I think before we met him, he had 11 hospitalizations in a year. He had tremendous success with hospital at home. He was able to maintain his function and independence much longer, and I think just have a much higher quality of his remaining years and avoid institutionalization. And then he ultimately made the transition to hospice. He actually still calls us pretty often because he feels such a connection to our team and likes to give us updates. This one is near and dear to my heart as a geriatrician. We had a 97-year-old woman with advanced dementia who is admitted for an infection that required IV antibiotics, and she was having hypoactive delirium, not eating or drinking, needing IV hydration in the brick and mortar. There was a question of, is this the end of her life? Should we switch to comfort care? Had some conversations with her caregiver and decided, let's transition her to hospital at home. And if she starts, eating and drinking again at home, that's great. And if not, that'll be the term. We'll move to comfort care. But lo and behold, when she got home, she started eating and drinking again, which was really wonderful. We had another patient with very severe debility, total care with contractures and pressure ulcers. His family was doing the best that they could, but he was sleeping on an air mattress on the ground at home, and not like a fancy hospital air mattress, like a regular, like a blow mattress. We were able to get him on a hospital bed, his incontinence care supplies and personal care aids, and more importantly, worked very, very hard to ensure that his family, and he's a VA patient, that we set him up with these same services once he got discharged.
Some other folks that I spoke earlier that vast majority come from medicine world. We're trying to do our best to expand into realms outside of the medical or the mainline medical world. Hem-onc is a service we've been working very closely with. We've admitted a couple of neutropenic fever patients who are great to have in the home environment. Just last week, our neurology folks are super interested, and we've been searching for the right patient. And occasionally someone will get admitted who's got optic neuritis, these IV steroids for 4 or 5 days, and they're able to go home, and we're able to work with neurology on how to do appropriate neurological assessments through the tablet computer that we have. And the other thing that's really exciting is one of my favorite stories is the efficiency of care that can be done with home hospital patients. So we work with IR and with our radiology folks. And I think 2 months into the program, we're able to bring a guy with osteomyelitis of the spine. He came in, he got an IR biopsy, an echo, and an ultrasound of his legs, all within like 3 hours, and then went straight back home. So it's efficiency that's built into the program to really help these patients stay in their home environment and avoid overnight stays in the hospital. A couple other things that we don't always think about is the issue of privacy. People are rounding in the hallway with large house staff teams and medicine teams, and there's discussion in the hallway and presentations, and doors are open, and there's a lot of talk and chatter, and that can be really difficult for patients with certain medical conditions. So a patient came in just a few weeks ago with acute hypoxic respiratory failure, unknown cause, a massive workup, got a bronchoscopy. People couldn't figure out what was wrong until finally some lab work came back, and she was diagnosed with PJP and AIDS. And she was married and had children. It was a very, very difficult situation for her. And once this diagnosis came, she was able to go home and be with her family. And I think that focus on privacy was really, really helpful emotionally for her as she began to kind of deal with this particular illness and what it meant for her in her life. So the aspect of privacy with home hospital was something that probably isn't elaborated much on in the literature, but is very helpful for a lot of patients, especially a subset of the population. Another case example, and probably one of our favorites of how complex people get, is there was a gentleman that was admitted for cryptococcal meningitis. And this was his third admission in the last 6 months, and the plan was for 6 to 10 weeks of IV antifungal therapy with amphotericin B, which, as those of you who've treated cryptococcal meningitis with that medication know, it's extensively difficult to do. You need IV fluid boluses before and after. You need multiple electrolyte monitoring of phosphorus and magnesium. It takes a long time. And so this process in the hospital was taken 4 or 5 hours a day. At this point, we had some staffing changes and we were able to enroll this gentleman in home hospital. And it was exceptionally complicated and time consuming, not only for the patient, but for our staff too. And there was a big discussion, is this an appropriate use of home hospital to take one patient that essentially takes 2 nurses rather than 1 nurse? But what ended up happening over the long term is that we were able to teach his family how to do all of this stuff. And so over 2 weeks in a home hospital, his wife and his son were able to learn to infuse IV boluses, infuse the amphotericin, and take him to an infusion clinic 4 times a week for IV mag infusions. So he ended up staying in a home hospital for a couple of weeks, but discharged about a month before he would have otherwise discharged from the hospital. So even though it took a lot of resources, it actually saved about a month of hospital bed days for this one person. And the family became much more literate in how to care for their very complicated mother. Also, that one guy really messed up our length of stay goals for the home hospital program. It's totally worth it, totally worth it. But that one outlier can really bump up the length of stays.
Okay, we'll talk a little bit more about some additional benefits. So improved mortality and readmission rates. So nationally, for hospital at home programs, there's a 7% escalation rate. So these are patients who were in hospital at home, had to be transferred back to the brick and mortar, and a 0.43% mortality rate. There's also nationally a 26% reduction in readmission rates. And with these statistics, I like to say if hospital at home was a pill, everyone would take it. At our hospital at home program, we will discuss our escalation rate on a future slide, but we have a 0% mortality rate. Additional benefits, improved function. Okay, so a randomized control trial showed unchanged safety and significant improvement in physical activity. Patients in hospital at home spent 18% of their daytime lying down compared to 55% lying down for those in the brick and mortar. And for those of you who are familiar with step counts, I thought this was a fun fact. The brick and mortar cohort, they on average took 160 steps in a day. That's very little. And the hospital at home cohort took 1,800 steps, which is almost a mile. So it's a really dramatic difference in how their physical activity that's allowed in hospital at home. There's also a significant decrease in use of post-acute rehab. And in our hospital at home program, our use of post-acute rehab is less than 1%. It's very low, especially considering that it's a mostly geriatric patient population. Some more safety. So nationally, there are lower fall rates for hospital at home compared to brick and mortar. At our hospital at home program, our fall rate has been around 4%. We only had 1 fall with injury. There are lower rates of infection. You don't get MRSA from your living room. There's less use of sedating medications, right? Patients are less anxious in their own home. They sleep better in their own bed. And when you're not anxious and you're sleeping in your own bed, you experience a little less pain. So we just don't need to use sedating medications as often as we do in the brick and mortar. There's also lower rates of delirium. In fact, at our hospital at home program, our rate of delirium is 0. Again, very exciting because we have a predominantly geriatric
You
patient
could argue it's
population.
negative. It's
Yeah.
people come in with delirium
It
and
is.
it's resolved.
It's like the antidote to delirium, in addition to treating the medical problem that caused it. Yes.
Can I ask a quick question? Who is your control group here? Is this people who were eligible but declined?
So these are the statistics are national statistics.
Oh, I see.
The randomized control trials where they've compared patients who would be eligible for hospital at home but then didn't do it, compared to those who
Got it.
did choose
So
to.
this is not, the control group aren't our patients who
Correct.
were eligible but didn't enroll.
Correct.
Okay,
That's
thank you.
a future opportunity for sure. So in health systems that have a hospital at home program, it's the safest unit in the hospital. All right, I'll let Gordon explain this slide.
Oh, yeah, transferred back to VCU. We mentioned earlier, there's been, as of 2 days ago, 297 people enrolled and 297 people who've enrolled in the program and discharged from anywhere in the hospital. Of that 297, 267 discharged from their home environment. So that remainder of 30 are folks who transferred back and discharged from somewhere else in the hospital. But we have to look more into the details as to that number. If you add that number out of 300, it's about 10%. But of that 10% that comes back, approximately 9%, it's not because they're clinically declining or there's an acuity change for the most part. The vast majority is people think they're great for the program and then we arrive home and suddenly their home isn't what they told us to be, or their caregiver who they said could be there actually isn't there, or that they can't physically get up the steps that they said they could get up, despite our work with PT prior to getting them home. So a significant portion is we get home and the home environment isn't what was promised. Another component of there are folks that they're brought back and then they need to stay overnight for one night, which will count as an escalation, and they go back into the program at home. There's a couple of folks that say they really want the program, and really we find that they just want to go home, and then they don't adhere to the program policies once they get home. For those folks, we offer either they can just discharge or they have to come back to the brick and mortar if they're not going to adhere to the program policies. But of that 9%, only 30% of the 9%, so about 3 to 5% of our home hospital patients actually clinically deteriorate and need to come back. And of those that have been brought back, there's been no mortality on the transfer. People come back, get stabilized, and do well and discharge from the hospital.
Yeah, and about 20% of these escalations eventually transfer right back to hospital at home to complete their hospital course. So let's talk about equity. There's a study in JAG in 2022 that showed that patients who had been discharged from hospital at home had lower ED utilization rates after hospital at home compared to traditional inpatient units. But the more exciting part is that there is an even more significant reduction in rates for patients with lower SES, which kind of highlights the point that only 20% of a patient's well-being has to do with medical interventions. And one of the most dangerous things we do as a hospital is to discharge someone. If you can just imagine how much more robust our ability to discharge plan can be if we're in the patient's home, actually seeing what resources they have, what kind of support they have, how they are or are not able to manage their medications. It's just a really unique opportunity to work upstream and potentially change the trajectory of a patient's quality of life. I like to say that this is concierge-like care for all. We had 1 week where we had someone on our service who was a CEO, and at the exact same time, we had 2 patients in our service who were experiencing homelessness, and they all received the same very patient-centered, on-demand, very high-quality care. So equity, health equity is a really hot topic in the hospital at home movement, because as these programs grow, we want to make sure that this is care for everyone. So I wanted to highlight some of the ways we're trying to address equity. So first category is housing. So we have this wonderful partnership with Doorways, our hospitality house. It is offered to patients who meet criteria for hospital home, but either live outside of the 25-mile radius required for participation. So we had a gentleman who lived a little outside the radius, older gentleman, who he was able to be at doorways. And actually the nice part is that he really benefited from having his family around him. So it was nice because his family could stay with him at doorways. This is also an option for our patients who do not have a home that is safe for providing acute care in the home. So, for example, we had a patient last week who needed a wheelchair, and her home had a lot of stairs in it. So while she was receiving her inpatient care, she was able to receive that at doorways. We also had a patient who didn't have a bed in her home, and we're able to take care of her in doorways. Someone who lived in like a group home setting with not enough privacy, and this allowed for a more private experience. And then we also offer this to patients who don't have stable housing. Like I mentioned, we've cared for several patients who are experiencing homelessness. Another category is communication. So we don't want to leave people behind who don't have the latest and greatest of technology. Wi-Fi is not required. Our RPM equipment that we lend patients uses cellular data. We can also lend a MiFi if Wi-Fi is needed to improve connectivity. A phone is required as an additional means of communication when patients are in our program, but if they don't have a phone, we've been able to lend patients a phone while they're in the program. We've had a number of patients whose primary language is not English. So we've had some Spanish-speaking patients. We had a patient recently who spoke Russian, so we're able to use the interpreters. One thing that we're really working on right now is having more support for our patients who are visually or hearing impaired. One of the ways that we're working on that is through our RPM equipment, making sure that it has adequate volume adjustments and print settings, and just also ensuring that patients have adequate support at home. And then the home environment. So we had a patient recently who had bed bugs, and we were still able to provide compassionate care in the home. And actually one of the things that was great is that so the patient and their caregiver were not able to afford treatment for the bed bugs. And we actually applied for foundation funds to assist, and we got approved and were able to treat the bed bug infestation. We have had a number of hoarders in our program. I think when people imagine taking care of someone in their home, you imagine this beautiful house on Zillow or something. But the reality is people come from all different spaces. And we have a number of patients who also because of their, medical condition are having a really hard time keeping up with taking care of their home. So we've had a number of patients where there's nowhere to sit, there's nowhere to put down your equipment. They live in that chair. And we've had patients who had a ceiling falling in, a lot of mold, non-working appliances, a non-flushing toilet. We've seen it all, and just a huge kudos to our just wonderful, very compassionate team that's identified a lot of different ways in which we can help some of these patients and help them find resources to have a safer living situation. We've also uncovered a lot of cognitive impairment. There are a ton of people living out there, living alone, managing their own meds, who are actually very much struggling to manage their own medications. And in the hospital setting where we're doing all the work, you don't uncover that. And patients say, oh yeah, I manage my own meds, whatever. But in this program, some of their medications are given by their visiting nurse or medic, but some of their medications are administered virtually. So we have our virtual nurse observing them taking their medication. And it's just been very eye-opening to see some of the challenges that people are facing in trying to manage their own medication. So, and some of them are very high-risk medications. We've had patients on insulin or blood thinners, diuretics, who are just really struggling to take them correctly. It gives you some insight on maybe why they're in the hospital. Because we've identified those challenges, we've been able to make some adjustments, like simplify some of their medication regimens, to pull in family members who maybe weren't really aware that this person was starting to struggle and could use a little more assistance, and other community resources. This is another category. I called it dependence, but you guys can offer a title as well. There's a lot of reasons why being in the hospital is just very disruptive. So we recently cared for a patient who was breastfeeding her 3-month-old, was able to do that in hospital at home and still receive their inpatient care. We had a woman who had just delivered newborn twins and then had cholangitis and needed like at least a week of IV antibiotics and very close monitoring. That would have been like a whole week or more away from these brand new babies. And so we were able to get her back home, give her the exact same monitoring, diagnostics, and treatment that she would have received in the brick and mortar, but with her family. We have patients who have work responsibilities. We have had patients in our program who, because they're in the privacy of their home, they can jump on a Zoom meeting, or, if they're feeling well enough, jump on a Zoom meeting, or, continue some of their work responsibilities that they wouldn't have been able to do in the brick and mortar. We also have a fair number of patients in our program who are responsible for another adult with disabilities, or being a primary caregiver, and there's no one else to take care of this person. They cannot leave this person. These are often the patients that come to our hospital and they've had a simmering medical problem for months. I mean, this is like they have waited as long as they possibly could to show up to the hospital because it is that problematic for them to leave their home. And so this is just like a really wonderful way to, actually provide the medical care that caregiver needs, while also helping them to continue to support the adult that's dependent on them. And then I put cats. We have a lot of pet lovers who maybe don't have someone else to take care of their pets. And one great example is we had a woman who comes to our hospital frequently, and she always leaves AMA after a day or two because she has to get back to her cats. So we were able to get her back to her cats, but still receive the IV antibiotics that she definitely needed. So safety is really important topic. We've talked about some of the medical complexity, some of the social complexity of our patients. And the patient safety, but I wanted to talk also about our team safety, because that's also quite important. It is a work in progress. We are always trying to get better at this to support our team. But I wanted to run through some of the things we've had to think about, because, in the brick and mortar, you don't have to go through some of these things. So here's some of the things we do at enrollment. So first of all, we consider whether the patient lives in an area where we've had safety concerns in the past. And during the screening process, we say, sometimes our nurse or medic has to do a visit at night. Do you have any concerns for the safety of visitors in your area at night? So if the answer is yes, we can consider whether doorways is a safe alternative, offer that to the patient. If the answer is yes, we can also ask them if there's another location, like a friend or family member, that would be a safe alternative. But if no alternative is accepted and the patient lives in an area where we have safety concerns, we have to think about some other things. How likely is it that an urgent or a scheduled visit will need to be after dark? If likely, then we'll skip ahead. If you're unsure about the safety of the home location, this is, we pull in the whole team to really make sure we discuss this and address it before they go home if possible. But sometimes there are home visit safety concerns that come up after the transfer to home. So this is an active hospital at home patient. So again, we go through the options. We could transfer them to doorways. We could see if there's another location they're willing to go to. Whenever possible, we try to have 2 visiting team members go to each visit if this is an area with safety concerns. We are newly staffed for paired visits in the evenings. We're actually in a few weeks going to be utilizing patient care techs to do paired visits in the evenings. We're trying to schedule visits during daylight hours whenever possible. We have a patient currently who lives in an area where we've had some safety concerns in the past and current safety concerns. And we're doing paired visits even during the daytime. We have company vehicles to also try to increase safety. We have some just general safety recommendations, drive around the area first to survey for any safety concerns, park only if you feel safe to do so. You can call the command center. That's where the virtual nurse and care coordination support is. That team can stay on the phone with you. They can stay on a video with you. If you have safety concerns, you can call the police. You can also ask to be escorted from your car by the police. We have things like sharing your location. The bottom line, I think, is like really trust your gut, use your team and resources, and do not put yourself in a situation in which you do not feel safe. So if urgent medical care needs to be provided, we cannot safely provide it using all these resources, then the patient would have to be transported back to the brick and mortar. This is also, we have a fairly long patient care agreement that we review with patients when they get enrolled in the program, because there are some, rules to receiving inpatient care in your home. But these kind of highlight some of this is just part of it, some of the safety concerns. So like all firearms in the home will be stored in a secure and locked location. No illegal substance use or drug paraphernalia in the home. Refrain from consuming alcohol for the entire time or smoking from the entire time that they're in a patient in our program. We've had a fair number of patients who, drink alcohol every day or, are daily smokers. And we will take those patients in our program. They just need to agree that they will not do that while they're in our hospital at home program. Another issue that actually comes up more often than you'd think is any animal residing or visiting my home will be contained in a kennel or secured behind closed doors while the team is in the home. And then this is like the best parts, patient satisfaction knowledge.
Oh yeah, this is fun. So HCAP's stuff, this is the survey for home hospital. I was going to do a big comparison to all the other units, but home hospital is so unique. It's really a different type of comparator. So if you look at total patient satisfaction with home hospital patients compared to folks who stay at the brick and mortar, the patients tend to answer questions in a slightly different way. And what I found fascinating about this is rating the hospital was quite low if you look at it. Mainly quarter 3 was quarter 2 fiscal year was bad. But overall, they rate the hospital a little bit lower, but they would recommend the hospital quite well to other people. And I think what happens is people enroll in home hospital, they love being at home, they love the patient, the care that they get, they love the attention, and it makes them think even less positively about the brick and mortar hospital. So it's an interesting dynamic in how they rate the hospital building itself versus the program and the care that they're receiving. Other things that really focus on patient satisfaction and safety is like the nurses. The patients in the program love the nurses. Nurses are in their home twice a day. They get to know the patient. They get to know the patient family members. They get to really develop rapport and talk to the patient and get to know them more deeply than they otherwise would within the brick and mortar where they're running around seeing a bunch of other patients. When they're in the room with that patient, the focus is on that patient. There's less pages about other folks who are having issues. It's a total focus on the patient at hand. Communication with the doctors also has been really, really high with the folks that have selected to work with home hospital, our hospice providers, and been really, really happy with the type of communication our providers have provided to the patients, as well as, and the patients are very satisfied with it as well. And again, you go down, once they're in their home environment, they look back at the brick and mortar and say, maybe the brick and mortar hospital is a little less clean than I thought it was coming in, because they're at home recovering in their environment. So it'd be interesting to track these figures over time as we look at the communication and stuff that's already positive and figure out ways we can use these statistics to maybe improve stuff here at VCU or have some sort of better parameters for evaluating what these numbers actually mean.
All right. We also have a MyChart survey, and we have 100% overall rating of excellent or very good, which is just really wonderful. We get these great quotes from patients filling out the survey. So I'm going to read a few of my favorites. The total nursing staff and everyone who had anything to do with my care was exceptional. The team was awesome, and I felt included in my care. I'd love to do this again if you'll have me back. The nurses, were all wonderful, excellent service. Home hospital was incredibly well organized and was carried out very efficiently. Actually, I received much more individual attention than I would have in the hospital. Being at home was far more restful and conducive to healing than in the hospital. I was extremely pleased because I never felt alone or ill-equipped to handle my care. The welcome surprise was the effect that the additional attention, rest, and privacy had on my recovery. I received 5-star healthcare and prefer it to being in the hospital. The care was excellent. I was able to rest and recuperate in the privacy of my home while still receiving the same level of care and attention. It made such a difference that I would strongly recommend this program to others. Everyone was so supportive and concerned about my health. I would recommend the service to everyone who would need it. And this patient, I was hoping to do an interview with today, but he's an active patient in our program, so he's busy. But this is a quote from him. He said, "I would not want any other hospital for my care in the future. I told my family if I needed medical help, take me to VCU Hospital for my care, no other place." This is the best experience. I felt so cared for by all the staff. The nurses are excellent and all go above and beyond, and my doctor was the same. All over, excellent experience. Also, I feel more confident in my abilities. Love it. They took time with me and showed me care. Home hospital overall was a great experience. It was comfortable being in my home for care. The nurses and doctors were wonderful. I was trained, informed, and updated very well. The best hospital I've been to. Home program is amazing. It was a true boost to the mental health aspect of healing.
And I'd like to kind of nearing conclusion of a case that happened just a couple of weeks ago when I was on. And it sounded like it was going to be a great home hospital patient. And what I want to talk about is not only the VCU home hospital program, but also how we're trying to integrate it with all of other VCU's programs that are providing home-based care. So it was a 93-year-old man who had come to the ED a couple of days prior, had blood cultures drawn, everything looked fine, they sent him home. He's got pretty significant dementia, baseline supported family. He got called 2 days later because his blood cultures were positive for coag negative staph. So they brought him back and they admitted him for IV medications. While he was in the hospital, he began to have worsening delirium, as one may expect of someone with his age. The family was really concerned, and the son would just say, "Just get my dad home as quick as you can. He just needs to be at home. He wants to be at home." So we're like, "Great, let's enroll him and we'll prevent his delirium, and then we'll rule out this negative bacteremia and he'll be great." He transferred to home hospital on day 2 of hospitalization and looked great. The second day while he was in our hospital at home program, he suddenly had increasing oxygen requirements. He suddenly became a little more lethargic and a little less interactive. And he looked very concerning for us. The in-home RN alerted me and we had of how rapidly this gentleman was deteriorating. And I was able to call and talk to the nurse who was in the home at the time and discuss what the next steps were. The nurse expressed some real concerns that his breathing was more labored and he was having a really hard time. The nurse then proceeded to spend 2 consecutive hours at home, helping out the family and figuring out how we could best manage the patient in the home environment. The family at this point was adamant that they did not want him to be brought back to the hospital and that they wanted him to stay at home. And that's where he would want to be. He got worse and worse, and suddenly he was on 4 liters and then 5 liters. Which is the max oxygen we can require at home. And he became more lethargic and was communicating even less. We had a goals of care conversation with the family and the nurse, and the family decided that their father would not want any more hospital care and that they wanted to make him comfortable at home. At this point, it was 6 p.m. on a Friday afternoon, and I called VCU Beata Hospice, and they got back to me within about 5 or 10 minutes. And I had the nurse liaison who was up in New Jersey and cares for the weekend call me back. And we chatted for a while. And I said, is there any way you can enroll this person in home hospice? We need to be able to get him medications at home so that he can be comfortable in his home environment because he looked like he was getting worse. And they accepted the patient. And within 3 hours, a nurse from in-home hospice came to the patient's house with medications. The patient overnight passed away just several hours later, 6 or 7 hours later. But with the coordination with VCU's Beata Hospice program and our home hospital program, we're able to discharge the patient from home hospital and provide in-home hospice care within a 3-hour time frame and allow the patient to pass in his home where he wanted to be with his family at his bedside. I got a call 2 days later from the patient's family asking how to return the remote patient monitoring kits of all things. And the discussion we had, the son, this delightful gentleman, said, we don't know why anyone would not choose this program. The nurses were exceptional and caring and spent so much time with my father. This program, so communication and coordination of care, allowed my father to be in his home when he died, which is what he would have wanted. So it's not everyone does wonderfully at the end of home hospital. There are people at the end of days, but being in the home environment with their family and with the comprehensive care that all of VCU's home-based programs can provide is a really, really of great benefit to patients and their family members.
So now we've got some very high levels of dopamine. So I just wanted to conclude that, the hospital at home movement is, as it says, coming on strong. There was, we were actually featured in an article in the American Association for Physician Leadership. It was us and Mount Sinai and MGB, Mass General Brigham. Those two are academic leaders in this movement. It was really exciting to be featured right along with them. VCU Health is leading innovation. We're our hospital at home program is the only program of its kind in the whole state of Virginia. It improves our health system's capacity. It improves patient outcomes. It improves patient and care team satisfaction. And it aligns our health system with the future of healthcare delivery.
Oh, how to refer a patient. I see a lot of folks who practice hospital or in the hospital taking care of patients. So this is how you do it. You just go up, if you're ever in the hospital, or you got house staff team members, you can instruct to do this too. You just type in home hospital. You just type in home in the order set, it'll pop up. And then you order a home hospital assessment. It's ideal you put an indication there, but we don't care. Just consult us and we'll figure it all out. The more consults, the better as we start to grow the program even more.
Thank you guys so much. Any questions? Yes.
Order one from the MRICU if they're just boarding.
Yes, we have. The question was, can we order one from the ICU? We have had at least one, I think maybe two patients, and these are great folks. They come in with COPD, they need BiPAP for 12 hours. They can transfer from the ICU directly into home hospital as long as they need only acute level of care. We've done it a couple of times.
Mm-hmm.
I don't know if there's questions from if the question thing is set up on it.
Any other questions here?
Just thinking about like the health equity side and what they can get at home. You mentioned that you will offer food, and we were just chatting about, we're feeding our patients in theory when they're in the hospital. So I don't know if that's come up at all.
Yeah, so one of the requirements for this type of program is you have to offer everything that the brick and mortar can. So we offer food, breakfast, lunch, and dinner, any supplements that the patient needs. And we have a surprising number. It is optional. They don't have to accept our food. We have a surprising number of patients who would like our food, and they really like it. And then one of the things that we're also, paying attention to in the home is any like food insecurity. And oh my goodness, the amount of patient education that our team does is just really incredible. Yeah. Yes.
And I can't remember if you guys mentioned this at the beginning, but are you able to take patients as like direct admits from clinic?
So no, I wish we could. That's future state. Oh, sorry. The question was, can we take direct admits like from clinic? Future state, that's probably coming. But the way the regulations are now, they do have to make a stop at our brick and mortar, but they can come directly from the ED as long as they meet inpatient criteria. Oh goodness, let's see. There's lots of questions.
Yeah.
Yeah. Top of the hour. We'll take one more question from the inpatient, and then we can see if we can respond to the chat.
I was just wondering, when a patient gets re-escalated, how do you guarantee that they have a bed if our facility is often full?
Yeah, the question is, if a patient's escalated back after being in a home hospital and there are no beds, what happens to that patient? Home hospital patients are admitted, so they take priority over every other patient pretty much in the hospital. So we will get them a bed. Occasionally they'll have to stay in the ICU, or we'll find a CDU bed, or find some bed down in the ED if there's not one upstairs available. But these folks can go to anywhere in the hospital where there's an available bed. Jay, I will say, Jay's always on top of things. He corrected me. I said 300 patients, 350. The 297 was a rolling 12-month average. So it's over the last 12 months. So since the inception of the program is 350 patients. Julia's reading through some of these questions.
Trying to read through them, but luckily our team is on the chat and answering a lot of these. Thank you so
Good
much.
job, Noreen, answering all the questions before we get to them.
Anything else for our presenters? All right, thank you so
Yeah,
much.
thank you.